Hi. Good evening, everyone. Are you guys able to hear me?
Yes, thank you.
Okay, that's great. Yeah, thanks, Davis. Thanks, Eamon, for correcting. Okay. Um, yeah, really, good evening, everyone. Really, thanks for joining today's session. Um, and I think I see some of you on Tuesday's session as well. So, hi, Akhilesh. Yeah, so we have Akhilesh here today. He's also a member from the SUPTA team. So, um, I'll hand it over to Akhilesh first. To and yeah, we'll see you guys in the teaching session in a while. Yeah.
Hi everyone, thank you for joining. Like you said, my name is Akalesh and I'm one of the education coordinators at SUPTA. So this week we'll be focusing on upper GI surgery, and I think it's a PBL session. So we're really excited to have you here at the moment. And today I'm joined by Joe, who's going to be delivering the session, and he's going to be going through upper GI surgery, and he is a fourth year from Southampton. And just to make to make the session as engaging as possible, we'll be releasing polls throughout, and these are completely anonymous. So we really do encourage participation because it'll help your learning at the end of the day. And if you have any questions, just pop them in the chat and we'll try and address them. And at the end of the session, we will share a feedback form. And if you complete that, you'll receive a certificate of your attendance and also discount codes for, I believe, Teach Me Surgery and Pass the MRCS. And we're also really excited to share that we have a question bank along with additional resources like the session recordings for these sessions, which will be available on our learning portal. And those are all accessible through our website. And finally, just before we begin, I'd really like to thank our partners, Geeky Medics, the MDU, More Than Skin, Teach Me Surgery, and Pass the MRCS. And I'll hand it back over to Joe to teach the rest of the session.
Okay. Yeah. Thanks a lot, Akhilesh. So I think we got 12 people right now, but I think we can make a start first while we try to uh wait for a few more people to join. Okay, so without further ado, so like Akhilesh mentioned, so today's session is a PBL based session. So it's meant to be a bit more interactive. So there is definitely going to be certain parts where I'm going to be putting out things, just for discussion. So would really appreciate if everyone could participate. Um and because I don't think I'll be able to see the chat, so might need your help, Akhilesh, or even better, if you guys can directly voice out, that would be great. Okay. So yeah, without further ado, so let's start today's session. So today's session is upper GI surgery. So last session we talked about upper GI bleed as well as two malignancies, esophageal and gastric cancer. Whereas this session, we're sort of going to focus more on the other organs in can sort of think like the in the nine quadrants of the abdomen. So we're going to explore anatomy of the biliary tree, its relation in the abdomen, as well as the anatomy of the pancreas, and its vascular supply, nerve innervation, etc. And we're also going to talk a bit more about different causes of jaundice, like for example, prehepatic, hepatic, and post-hepatic causes. And from there, we are going to explore a bit more through different pathologies. So, how we are going to do this is I'm going to use a case. So, this case title is, as you can see here, it says yellow matters more than meets the eye. So, imagine if you are in ED, so you have a 54-year-old woman who comes in today complaining of yellowing of her skin and eyes that she have noticed over the past week. So, what questions would you guys like to ask? You can think of me as like the patient. So you're trying to clerk and get more information. So, what question would you guys like to ask me so that you can get a better understanding of what's happening?
We do have some people typing in the chat, so I'll
Okay,
relay
sure. Can
whatever
wait
their
for.
questions are.
Yeah,
So
yeah,
someone's
okay.
asked, what, do you have pain anywhere?
Yep, I have pain. Pain is in my can say it right here, the upper right side.
And we've got, do you drink alcohol? And if yes, how much?
Uh, I do drink alcohol, but I would say probably socially. So doctor, I really need your help now. You know, I'm in a lot of pain.
Someone's asking about the color of the color of urine in the stools.
Okay. Yeah, I've sort of noticed like these past 3 days, my stools have been a bit uh like lighter in color, and urine. Yeah, I think it seems to be a bit darker as well.
And any recent bowel changes?
Recent bowel changes. Not that I've noticed of.
Any recent illnesses?
Uh, no.
Oh, we still have a few more people typing.
Okay, that's good. No worries. I can wait. Yeah.
When did you start notice the yellowing of your skin?
Uh, I think about a week ago, like I just finished having a bath, and when I look in the mirror, I think then I noticed I seem to be a bit yellow. So I went to ask my husband, and he said yeah. He said, dear darling, your eyes does looks a bit more yellow. So that was like, oh, I was a bit, taken aback.
Have you had previous episodes of this problem before?
Um, I mean, previously I think I had went to the GP of similar pain as well, and then they sort of mentioned like there's some stones and such, but I think it's worse this time.
Have you traveled recently? And have you had any flu-like symptoms like fevers, nausea, or sweats?
Yeah. No, I have not traveled recently, and in terms of yeah, I think I had some chills and like feel a bit I'm shaking a bit recently and fever. Yeah, I think I do feel a bit hot and cold over the past few days.
Do you ever notice that the bowel or urine color changes more after you have meals?
Sorry, regarding meals, is it?
Did it change more after you have a meal?
Does it change water? Mm, I think so, but sorry, I didn't really notice that. Yeah.
I don't think anyone else is typing in chat, so
Mm. Okay,
at the
but no
moment.
worries. Okay. Thanks a lot, Akhilesh. Appreciate it. Yeah. So thanks guys for participating. Okay. So based on what you guys have asked earlier, so yeah, here are some further history. So uh this 54-year-old woman actually presented with uh so actually there's something to be the pain could have explored a bit more, I think. So the right upper quadrant would say is sort of like comes and go, is a bit crampy, doesn't really spread anywhere, and usually it comes after fatty meals. And yeah, you guys did ask about associated symptoms which include fever, and chills and wriggles, as well as the dark urine and pale stools. She did actually felt a bit nauseous, but have not vomited yet. Also has been feeling a bit more tired than usual. Um, and no history of trauma, no weight loss, night sweats. So, oh sorry. Okay, yeah, I can check. So here's his past medical history and comorbidity. So, Um, let's say Mary, let's say my name is Mary. So Mary also has high cholesterol levels, is on simvastatin, occasionally takes some over-the-counter painkiller, just a social work drinker and works as a teacher, doesn't smoke as well. Okay, and as you do your examination, so you find there's tenderness in the right upper quadrant with positive Murphy sign. No palpable masses, slight you feel that the liver border is palpable, you know, beneath the subcostal region. She does appears jaundice, with yellowing of sclera, and when you measure temperature is 38.5, pulse is 100, BP is 120 over 75. So based on what we've talked about so far, what what do you guys have in your mind? What could be happening here? Like, what are some of your differentials?
We've got cholecystitis,
Polycystitis, okay.
cholangitis,
Cholangitis, okay.
hepatitis.
Hepatitis, okay. That's quite a all good ones. Okay, so I think gave us three good ones. So okay, so we talked about differentials. So probably we can split it systematically wise to think about it. So um if you're talking about infection here, so could it be possibly acute cholangitis or an acute viral hepatitis? Whereas if you're talking about inflammation, like of the lining of the gallbladder, then acute cholecystitis. Whereas could it also be cancer, a pancreatic cancer? Or could there be an autoimmune cause, be it primary biliary cholangitis or primary sclerosing cholangitis? Okay. So at this point, while you're thinking about all these different shows, what would you guys like to do next? What's the next step?
LFTs,
NFTs, okay.
LFTs and FBC.
NFTs and FVC. Okay. What are you particularly looking for in FVCs, and what would you expect the LFTs to show?
If it's immune, then there'll be an increase in white cells.
Okay. That's a good thinking. Okay. Yep. So thanks for everyone who replied. So yeah, some probably bedside tests which you could do first is like full blood count, where you can check whether the person is anemic, like you mentioned, white cell count, see whether there's any underlying infection, um, CRP as well. That's another inflammatory marker. Depending or not, some places might use PCT. Um, yeah, and LFTs. Yeah, so you it's likely to see like raised transaminase enzymes, so ALP, um uh uh alkaline phosphatase, and alanine transferase, as well as GGT. But of course the levels will vary differently because ALP is not only um attributed is not a biomarker solely attributed to the liver. There's also like when there's especially bone remodeling, ALP levels can be affected as well. So you want to check your coagulation profile, especially if your liver is taking a hit, because your liver is the one that produces the coagulation factors. And We want to also check UNEs, if person's urea level and whether he's having any AKI. So those are bedside tests along with blood cultures as well, especially if you're suspecting um uh an infection or possibly sepsis. So in sepsis, to what investigations should we do? Like, have you guys heard of any acronym for sepsis? Or how do you manage sepsis patients?
We have a few people typing.
Okay.
Someone said sepsis 6.
Sepsis 6. Yeah. Could you guys mention like what's under sepsis 6? So they say you take three and you give three. So what are the three things that you like to take or investigate further, and the three things that you want to give to the patient to help them?
Someone said give IV fluids,
IV fluids, yep. So that's something you give.
blood cultures, take lactate, blood cultures, and urine output.
Yep, brilliant, spot on. But giving earlier you guys
So
mentioned
giving, we've got
fluids.
IV fluids and antibiotics and oxygen.
Yeah, okay, brilliant. So yeah, I think those are like those questions which consultants always try to ask as well. Yeah, so good to have in mind, and also when you're training and practicing later on, I think those are the things that we can always fall back to whenever we are suspecting someone's having a infection. And sepsis is quite uh serious condition that can escalate quite quickly if not managed well. And so those are bedside tests that we can do, of course, as well as taking vitals, measuring someone's new score. Um, in terms of imaging, so there are some options which include ultrasound, which can be readily be done by GPs in primary care, MRCP and ERCP. Does anyone knows the difference between MRCP and ERCP?
MRCP is non-invasive.
MRCP is not in. Yep, correct. Is there anything else?
No, that's been the only answer.
Okay, that's good.
And we've got
So,
one more person typing.
oh, okay.
Maybe someone said X-ray for the other.
X-ray for the other. So MRCP stands for magnetic retrograde cholangiopancreatography and magnetic resonance cholangiopancreatography, whereas ERCP is endoscopic retrograde cholangiopancreatography. So um MRCP is basically using magnetic waves, so like MRI. So MRCP and ERCP, the difference between it is both are diagnostic tests, and you're trying to find if there's any stones, but only ERCP is also a therapeutic test, because ERCP is where you're putting in a camera, so you can actually insert in a stent. Um, yeah, you can take in a stent, and you can also to remove stones. So that's why it's both a diagnostic and therapeutic test. Whereas for MRCP is purely a diagnostic test. Okay. And okay, and how will you manage this patient? So his 54-year-old woman comes. to you in ED, 1 week history of jaundice, has fever, you know, and she's in severe, quite bad pain. Mm,
We had some people typing.
okay.
Um, someone said MRCP.
CP. Yeah, yeah. So at this stage, you've already done the investigations, but how will you manage this patient? Like in this case, at this point, what do you guys think is the most likely diagnosis?
Someone's asking what was the blood pressure.
Blood pressure. Blood pressure is normal. It's like I think 100. Sorry, 120 over 75.
And someone else said if it's a gallstone, remove it.
If it's a gallstone, remove it. Okay. Okay. So so you want do you, does that mean you want to proceed with surgery?
And one other person's also asked what the imaging result was.
The imaging result was okay. Let's say because ERCP and MRCP take some time. So in ED they did ultrasound. Yeah, they found a stone. Let's say roughly around D2. I think the key thing here is trying to, what likely diagnosis are you guys thinking in your mind right now? Because that can severely change the direction of your management. And I think that you guys asked quite important questions earlier, like okay, like pale stools, dark urine. What is that a sign of?
We have a few people typing.
Okay. Yeah, thanks a lot, Akhilesh. Yeah.
You know you can't see the chat, so I just don't want you
Uh,
to be sat in silence. For someone,
mm,
one person said remove it. I'm assuming with the gallstone.
okay. Okay, I think okay, those are good thoughts. I think probably we need to backtrack a bit here first. So the question you guys asked, pale stools, dark urine. So that's a sign of obstructive jaundice, meaning there's a blockage somewhere. If you remember your anatomy, so most usually like either the common hepatic duct or the common bile duct can be affected. Like imagine a stone there. So that's why dark pale stools is because uh bilirubin, and conjugated bilirubin undergoes the enterohepatic circulation. That's why your urine is a bit darker and your stool is a bit paler. So that's a sign of obstructive jaundice. So that's a you sort of know that this person has a stone, but he also presents with fever, right? So if I go back to the side, so fever, um, okay, so fever usually points more towards an infection or inflammation. I mean, in malignancy, you could have it as well, but looking at the timeline of this thing is quite acute. So probably, we can put malignancy on one side first, and autoimmune wise is also over a period of time. So probably we can park that aside as well. So that leaves you infection or inflammation. So in acute cholecystitis, you actually won't get obstructive jaundice signs, meaning like pale pale stools or dark urine, because what's happening is inflammation of the gallbladder due to possibly stasis of bowel, um, or there's some perforation, anything like that. So because the stone is actually not lodged, in the biliary tree, whereas in acute cholangitis, you would have systemic signs which include fever. Hence, actually, the most likely uh, diagnosis here is actually ascending cholangitis. So what you want to do actually is to immediately like resuscitate, because patient is at risk of sepsis. So you need to admit him on a ward. Provide broad-spectrum antibiotics, either tazocine, which is piperacillin tazobactam, or ceftriaxone, metronidazole, for gram-negative cover, as well as IV fluids and analgesia, because he's severely in pain. And if he's vomiting as well or he's feeling sick, you need to give antiemetics. Um, so that is what you like immediately what you need to do. After that, you can um because the stone is the one that's causing like obstruction, so there's stasis of the bowel, bowel kind of flow out, and then that's why that even worsens the infection. So you need to remove the stone. So possibly an ERCP is your definitive management. And so what you guys have mentioned is right. And then post recovery, you might consider doing a laparoscopic cholecystectomy, which we'll talk more about later. Okay, so appreciate you guys for participating in that. Because in one session on Tuesday, you guys mentioned wanted it to be more interactive. So actually would really appreciate if you guys could voice that out to me, because again, it's just the few of us here. So this is a learning session between all of us. So I think that would be better way for all of us to learn. So anyways, now we'll come to talking about the facts. So regarding anatomy of the biliary tree, so first you need understand how the bowel system works. So bile actually is produced in the liver and then is emulsified and stored in the gallbladder. So there's the right and left hepatic ducts, which comes from multiple confluences of bile ducts in the liver. So they join together to form the common hepatic duct. And the common hepatic duct advances down, joining together with the cystic duct to form the common bile duct. So that's your biliary tree right there. Okay. And the few organs in relation here is your liver, which is anterior to the gallbladder. Gallbladder is sort of behind in the gallbladder fossa, as you can see here. So this is like a posterior inferior view of the liver. So liver, you have your right lobe, your left lobe, and then the diaphragmatic barrier. Okay. Um, and then anterior to it, and you have the uh duodenum. So some parts of the duodenum is retroperitoneal, but the duodenum joins from the pylorus of the stomach. Okay, and some other important structures as well include the pancreatic ducts, which we'll talk more about later. Okay, so clinically, what's important? So there's something called a Carlot's triangle. So if you imagine this triangle here, so there's so let's talk about the roof first. So superiorly is the inferior border of the right lobe of the liver. Okay. And medially is the common hepatic duct. And inferiorly is your cystic duct. So up is your inferior surface of your liver. Medially is your common hepatic duct, and then your cystic duct. So they form the Carlot's triangle. So what's important is because in this space itself, or this triangle, is located the cystic artery, uh, and of course the cystic duct is below. So you want to be careful and identify this structure because you want to ligate it when you are trying to remove the gallbladder by clipping, and then they make the ligation. Okay, and then coming to anatomy of the pancreas. So the pancreas have a few parts: the head, the neck, the body, and the tail. So this shows image of pancreas, the head at the left. So pancreas is quite a unique organ because it have both exocrine and endocrine functions. And so there's a lot of ducts here. So you can see mainly there's the main pancreatic duct and the accessory pancreatic duct, which joins the from the confluences of pancreatic ducts out before they come out to form the main pancreatic duct, which is also known as Wilson's pancreatic duct. So the main pancreatic duct actually comes out through the major duodenal papilla at the ampulla of Vata. So there's like a sphincter, like opening and closing, sort of like a valve, where the pancreatic exocrine contents go out into the duodenum. Okay, and here's the structures of the pancreas in relation to other organs. Okay, and it's quite crucial, I think, to get to know some fundamentals or basics of radiology as well, like what you're looking at, especially on your surgical placements. So if you look on a axial CT scan, so imagine the body, you cut it this way. So here's your liver, okay? This white thing is your vertebra, okay? And the black space or usually is fat, and this black color is sort of like air, okay? And here is your pancreas. And this is the frontal CT scan. Okay. Um, okay. Yeah. Okay, so now let's talk about jaundice. So what is jaundice? So jaundice is a term used to describe a clinical finding of yellow discoloration of the body. And this usually happens due to hyperbilirubinemia. Okay, so bilirubin is actually a breakdown product from like our red blood cell breakdown. So when there's an excess of bilirubin, usually it will lead to jaundice. But there can be physiological jaundice, like breast milk jaundice, or pathological jaundice. Okay, so there's an imbalance between production and clearance of bilirubin. So you can see here actually, so heme when in your red blood cells, so it's actually through the action of biliverdin is converted into unconjugated bilirubin. So bilirubin gets conjugated in the liver itself. Okay, so that's also a key sign to know because different conditions can present with either conjugated or unconjugated. So you can measure the levels lah. For example, like in biliary atresia, you usually get high levels of conjugated bilirubin. Okay, so pre-hepatic, so we can split causes of jaundice into like pathological wise into three different categories. Pre-hepatic meaning anywhere before the liver, hepatic anything in the liver, post-hepatic anything after the liver. So like kidneys or anywhere else. So usually pre-hepatic has a lot to do with your vascular or your spleen because a lot of it is like membrane defects like spherocytosis, you have microangiopathic hemolytic anemia, G6PD deficiency, sickle cell anemia, thalassemia, okay? Things that have to do with defects in the sort of like the component of the red blood cell itself. Okay. Whereas for hepatic causes, it can be hepatitis or metabolic causes like hemochromatosis, like excess deposition of iron, Wilson's disease, like extra your body has so much copper that it that just deposits all around the body, can have cardiac fissure rings like the sign in your eyes. Vascular causes like ischemic or Budd-Chiari syndrome or even cirrhosis. There can be some genetic causes as well, like Gilbert syndrome or Crigler-Najjar syndrome, which are the common ones. Now we come to post-hepatic. If you see someone comes in with yellowing of the skin and you're suspecting a post-hepatic cause, is most usually due to, for example, the autoimmune causes of um, uh, gallstone, like primary biliary cirrhosis and primary sclerosing cholangitis. You can have pregnancy, cholecystis, they call it yeah, and sepsis or like malignancy and cholelithiasis. Okay, so gallstone disease or names it as cholelithiasis. Okay, so gallstones can be of different color, shapes, and sizes. So you see something yellowish like this. Most usually its content is made out of cholesterol. So whereas if it's black color, or we also known as pigmented stones, is usually formed by bilirubins. Okay, whereas mixed stone is a component of both. So now let's come to acute cholecystitis. So acute cholecystitis is most often caused by gallstones. So patients suspected of having acute cholecystitis should be referred to hospital immediately. So what are some treatments that they do include? You want to put the person nail by mouth, um, IV fluids, analgesia. That's it. No antibiotics here because it's not an infection that's happening, it's inflammation. So what actually happens is, see, there's increased intraluminal pressure due to a stone being impacted in Hartmann's pouch. It's quite an important location as well. So this stasis of things here can actually lead to gallbladder distension, sludge formation, and can cause edema of the wall. Okay, and so there's usually a debate about, if you look at it, a lot of papers, I think it's still ongoing topic, like when should we do the lab chole, you know, and should we do it when patient is showing signs now, CRP 200, 300, or should we wait for it to settle down first? Based on NICE guidelines, the period to carry out lab chole after, diagnosis of gallstones is within 1 week. But surgery within 24 to 48 hours of emergency actually is preferable to delay, or uh is preferable compared to delayed or interval surgery. But if someone is very ill or size wise they're a bit bigger, um sometimes it can be a bit difficult to carry out laparoscopically, hence or they might be too ill, or their performance status is not good enough. Hence, they might opt for a percutaneous cholecystectomy instead. And in sometimes, in 20% of cases, it may be converted to open surgery because you may find that the gallbladder is already gangrenous or there's perforation. So that's acute cholecystitis. So if you look at this image here, this is a gross pathology. So there's signs of hemorrhagic mucosa, small spots, hemorrhagic, and you can see the wall is actually quite thickened. So there's actually fibromuscular hyperplasia, and these are usually chronic changes over time. So there are some other conditions. So usually consultants will say, like, if in your MRCS exam, they say this can give you like cookie points. So you've heard the term Murizi syndrome. So syndrome is where there's again, the biliary tree is your important structure here. So there's usually an obstruction of the common bile duct or the common hepatic duct, and this obstruction is caused by an external compression, be it multiple stones or a single large stone in Hartmann's pouch. So imagine this stone here, okay? If this stone gets so big that it sort of presses on here and it sort of blocks that pipe. You imagine like the really common bile duct is like a pipe. So that stone is pressing so much on it that it sort of blocks that flow. So when that happens, that's usually call it Mersey's syndrome. And um again, they can there's a possibility of so question I would like to relate to everyone is do you guys think the size of the stone matters? I think this question was asked to me once by a surgeon. Like if it's a very, very big stone, like for example more than 30 millimeters, or if it's a small stone, like less than 5 millimeters, does that change anything? Or does that what's do is it of any significance to the surgeons or surgical team?
Someone's asked, is it like with kidney stone where different methods can be used for different sizes?
Mm, different method can be used for different sizes. Not really. Because if you have a stone, I mean, it's either you do it ERCP, you put a stent in, and then you remove the stone. It's more so of what can happen. Or probably we can put it this way. Which do you think guys think is more likely to cause an obstruction? A big stone or a small stone?
Someone said if you have a larger stone that you'll be more at risk for Mersey syndrome.
Yep. Right. Okay. So do we so can we so practically we're saying like large stones causes obstruction, so it's not good and basically we should remove it. How about small stones then? If it's small and it's not really causing obstruction based on that logic, then why do we need to remove?
There's someone said that it's a possible site for infection, which increases the risk of cholecystitis to develop into cholangitis. And someone
Mhm.
else said because of the inflammation.
Yeah. Yeah. Thanks for the reply. So I think, but that applies to both large and small stones. Isn't it? And I think more particular for large stones where you have an obstruction there that causes stasis, it's easier to lead to infection. But if you think about it, so a large stone will cause because it's so large. So if it's in the biliary tree itself, so it gets lodged into the common bile duct, so that causes it's stuck there. So that can lead to ascending cholangitis and then also possibly acute cholecystitis if there's backflow. But small stones, small stones are the one that really spreads to other places. Like what else? If you remember, like causes of pancreatitis. Gallstones is one of the commonest cause for pancreatitis other than alcohol. So if it's a large stone, the chances of it migrating to other places is less likely because it causes an obstruction. Yeah. But small stones have a higher chance of spreading elsewhere. And if a person is having recurrent acute like pancreatitis over months, then that should alert to you, okay, I need to remove stones, otherwise it's gonna lead into bigger problems or troubles. And also it can cause fistulas. So does anyone knows the definition of fistula? I think this is something that which they ask in the MRCS as well. Yeah.
Someone said an abnormal connection between two lumens.
Two lumens. Yep, that's quite close. So yeah, that's quite I'll say quite close, yeah. So it's actually a connection between two epithelial surfaces. Imagine of your cell lining, so two epithelial surfaces. So yeah, it's very common actually to see fistula forms. But do you guys know where's the most common fistula from the gallbladder to?
Someone said that if they had to guess, it would be the duodenum.
Yeah, correct. It's the duodenum. And after that is like I think the ileum. So yeah, it's known as cholecystoenteric fistula. So imagine like there's sort of like that track between the gallbladder and the duodenum. So small stones particularly can migrate down there, and then it can lead to diarrhea, abdominal pain, jaundice, and most particularly bowel obstruction. So you have what is known as gallstone ileus. Okay. Um okay. So thanks, guys. So now we come to acute or ascending cholangitis. So acute or ascending cholangitis is actually more of a life-threatening condition compared to acute cholecystitis because there's an active, ongoing bacterial infection. So this is usually caused by cholelocholitisis, meaning there's a stone which is blocking the biliary flow. So that's known as cholelocholitisis, or it could be also caused by benign or malignant strictures of biliary ducts, pancreatic cancer, or parasites. Okay, and some common pathogens seen in ascending cholangitis include E. coli, Klebsiella, Enterobacter, and Pseudomonas. So I think this is quite important because I think they do ask in exams at times. Okay, and I think there's two when you're doing your clinical examination or something to remember like when doing clerking is Charcot striate and Raynaud's pentat. So when someone presents with fever, jaundice, and right upper quadrant pain, so they sort of fulfill that criteria for the Charcot striate, which should sort of point you towards thinking, oh, this is possibly more likely a acute or ascending cholangitis. However, when someone also presents with further signs of like hypotension and confusion, then it's also acute or cholangitis, but usually that's at an even more severe stage. So you actually want to sort of prevent it reaching this stage and treat it early when you have already see that someone's yellow, having fever, and pain. You want to get right to it immediately. Okay, so now we come to another cancer, which is known as pancreatic cancer. So, pancreatic cancer is a carcinoma arising from pancreatic duct cells. So, as mentioned earlier, because pancreas have endocrine and exocrine functions. So, endocrine they secrete insulin and glucagon, which helps with regulating blood sugar. Whereas exocrine they secrete pancreatic enzymes to help with your digestion. So because of this dark cell, a lot of it is formed by simple the cell lining is or the cell type is of simple columnar cells. So from this itself, it gives you a clue that actually histopathology wise, more than 90% of pancreatic cancer is actually due to duct cell adenocarcinomas. And the remainings are like cis adenocarcinoma and athena cell carcinoma. Okay, so what are some risk factors for someone developing pancreatic cancer? So, usually when someone's age after 55, smoking, I say usually there's about a 20% correlation of smoking with pancreatic cancer, diabetes, particularly new onset diabetes. So if, for example, if in GP, someone over the age of 55, like 60, he presents with diabetes out of a sudden, out of nowhere, that should actually spark like alert to you, like there's a red flag here, which requires further investigation. And also chronic pancreatitis, like recurrent events um, of pancreatitis, inflammation of pancreas, and also obesity, and as well as genetic mutations and association with syndromes. Okay, so we talk about cancer. So now let's talk about cysts as well. So okay, so cysts are basically for example, fluid inside a fluid is like a fluid filled sac. But depending on the contents of the cyst inside, it may not be fluid, like serious fluid. It can be mucinous, like filled with mucus. So that's what it describes mucinous cyst neoplasm. So um cysts are quite a thing which the HPB team take note of, particularly certain cysts, for example, IPMN. Because what is of importance note here is because they have sort of a malignant potential to transform into pancreatic cancer. So you look at the data here. So IPMN, also known as intraductal papillary mucinous neoplasm, um, is one of the most common causes of people undergoing pancreatic surgery, also known as Whipple's procedure, because cancer is usually diagnosed quite late. That's why it's one of the cancers with the worst prognosis, because it's really deadly cancer and it's not catch early. Hence, usually when they find a nodule in the pancreas through incidental scanning, um, a lot of times is IPMN. So and that's found in the ductal cells. So IPMN can be separated into branch duct or main duct. So earlier we talked about the ductal system in the pancreas, right? Your main duct, and then you have the accessory duct as well. So if it's a branch duct, the chances of malignant transformation is about 1 to 38, which is fairly significant. But if you look at main duct, if the main duct is involved, and usually on EUS or endoscopic ultrasound or ultrasound itself, you can find a characteristic finding which is known as fish mouth papilla. Okay, and there's also usually signs of a dilatation of the main pancreatic duct. If you look at the malignant potentiality, it can rise up as high as up until 85%. So that's a significant number there. That's why it's usually quite a debate, and also I think things that um HPB surgeons consider when coming to IPMN cases. Yeah, so this was what was mentioned earlier about IPMN. So they arise from ductal cells, and they are often multifocal and can be located throughout the pancreas. Okay, and yeah, so this is like just showing guidance of the algorithm. Okay, so when it comes to, so if someone is having suspected IPMN, or there's pancreatic cancer deemed resectable, so surgeons will carry out what's called as a pancreatical duodenectomy. So nectomy means removal of pancreas and duodenum. So there's two types of pancreatic resection: a Whipple's procedure or pylorus preserving pancreatical duodenectomy. We'll go into detail what is involved more later. But basically, in the Whipple's procedure, what you're removing is the whole of the pancreas, the gallbladder, a portion of your stomach, which is the pylorus, and the biliary tree itself. So there's quite a lot of organs involved. Whereas for the pylorus preserving pancreatectomy, it's sort of similar, except you don't remove that pylorus part. So what are some risks and complications here? So what's one of the most important like commonly seen complications here is pancreatic leak. So in the Whipple's procedure itself, there's actually three anastomosis form. So okay, yeah, I'll show this first, which is easier. So you can see here, so this is your stomach, this is your liver. Here your esophagus joins with the stomach. Stomach continues on. From here, the antrum, the pylorus continues on as the duodenum, and then your jejunum. So in the Whipples, your pancreas is removed, the biliary tree itself, the gallbladder, and this some portion of your stomach, which includes the pylorus as well. So once they remove these organs, they need to join back the organs that's remaining. Hence, they'll use hand-sewn anastomosis between the pancreas and the jejunum, what's known as pancreatical jejunostomy. So this is one anastomosis. Another anastomosis is the pancreas and the liver, also known as uh, uh, hepato-pancreatical pancreatial hepatostomy. Whereas another one is between the pancreas and the stomach, known as pancreato-gastrostomy. So among these three anastomosis, the pancreatic one is actually um uh highest likely to leak because there's a lot of things leaking out from the pancreas. So and there's also bowel leak usually. And also other complications can be observed include post-operative ileus, delayed gastric emptying, and you will develop type 3 diabetes because you no longer have your pancreas, you no longer have that endocrine function. So you need to be on lifelong diabetic medications. And others will also include proton pump inhibitors, uh, pancreatic enzyme replacement therapy, again to replace that exocrine function of the pancreas, and other minerals and vitamins. Okay, so I think this is just a brief overview of just a summary of what we talk about here. So we talk about jaundice through our case here today. Talk about like the different pathologies like acute cholecystitis, like ascending cholangitis, um, and pancreatic cancer. So actually, I have a few cases to show you guys. Um, yeah, if you guys can see my screen, okay. We can go through some questions if you guys are happy with it.
We just have one question before
Ah,
you move on to that. Someone just
um,
asked if someone was to have a pancreatic leak, could they theoretically present with Cullen's and Turner sign?
um, because Cullen's and Turner signs usually that shows periumbilical ecchymosis in it. So that means there's hemorrhage and there's a collection of blood beneath the skin. But a pancreatic leak is when there's an anastomotic leak. So that usually happens probably few days or week, or possibly week after surgery. Person will present with fever. So I don't think it will present with uh like Gray's Cullen's and Turner sign unless there's a hemorrhage involved. Okay, nice. So we'll is there any other questions? Okay. No. So let's go through some questions. So okay, number one, patient presented with pale stools, dark urine, and generalized pruritus. What type of jaundice is most consistent with these findings? C. Yep. Yeah, brilliant. So yeah, it's post-hepatic or obstructive jaundice. So pruritus is actually a sign also in obstructive jaundice usually as well. So during clucking, it's good to ask about that, and that's usually due to bowel salts, accumulation of bowel salts. Sorry. Uh, okay, so I moved here. So yeah, so pre-hepatic jaundice, no, you wouldn't really present with pale stools, dark urine. Hepatocellular, no. Physiologic jaundice as well, not really. So it's actually the obstructive jaundice is the one that causes it. So the second one, causative sign, uh, also known as painless jaundice with a powerful gallbladder. What do you guys think is most suggestive of? Is it gallstone obstruction, acute cholecystitis, pancreatic head carcinoma, or primary sclerosing cholangitis? Because it is pain. Sorry, C, because it's painless. Yep, that's a good spot, Kevin. So yeah, it's pancreatic head carcinoma. So yeah, so gallstones can usually cause shrunken fibrotic gallbladder because of if like repeated inflammation over time. Yeah, there's fibrous tissue form. But usually when you have Kosovan signs, which you feel there's palpable mass, palpable gallbladder, and person is having jaundice as well, but he presents without pain. There's usually a pancreatic head carcinoma. Jaundice can be sort of on and off and can appear at quite a late stage, especially when the mass is quite big. Yeah. So you can come to the third one. So 28, if you guys have any questions, please let me know. Yeah. So the third one, a 28-year-old man with history of ulcerative colitis, um, which is one of the two types of inflammatory bowel disease, presents with fatigue and pruritus. So when you do your labs, it shows elevated ALP and bilirubin. So when you, and further imaging reveals, MRCP reveals beaded appearance of intrahepatic ducts.
So
Sorry.
we've got B as two
Oh,
answers
B. Okay, yeah, you guys are right.
and three Bs.
Thanks. Yeah, it's primary sclerosing cholangitis. So that's sort of like a hallmark finding on MRCP. And so that's due to this beaded appearance of intrahepatic ducts. So beaded appearance is usually due to stricture formations and dilatations of the ducts in the liver itself. So PSC, primary sclerosing cholangitis, and primary biliary cholangitis are both autoimmune conditions affecting intrahepatic ducts. Um, but there are some differences, which include some risk factors as well as investigations that you do because the biomarkers are a bit different. So PSC itself has a strong correlation with ulcerative colitis. Okay. Okay. Any questions? Or if not, we move to the new one. So, number four, a patient with acute pancreatitis develops hypocalcemia. So, what mechanism best explains this finding?
We have a B.
Boy, is it? Sorry, Akash.
Pardon?
Is B, is it? Sorry.
B, yeah, B. We have two
Oh,
Bs.
okay. To be okay, the answer is actually C, fat necrosis binding calcium. So usually when inflammation happens, fat strands will form. And in pancreatitis itself, you can actually see fat necrosis. So inflammations happen, and then over time, if there's chronic, particularly, it can lead to necrosis. So fat necrosis in pancreatitis actually leads to saponification. Uh, sorry, which is breakdown of fat, and that process itself actually consumes calcium. Yeah. Um, Vitamin D deficiency. I mean that could be that could be a sign coming together with hypocalcemia, um, but what uh leads to someone with acute pancreatitis developing or showing hypercalcemia is due to this fat saponification process where fat necrosis itself binds attracts calcium. Does anyone has any questions on this? No? Okay, we move on first, but let me know if there's any question. Okay, now, a 3-week-old baby presents with persistent jaundice, pale stools, and hepatomegaly, and serum conjugated bilirubin is elevated. What's the most likely diagnosis here? So earlier we talked about there's unconjugated and conjugated bilirubin, and like where unconjugated turns into conjugated. Where's the place that this thing sort of happens, like the factory.
I've got an
A,
A and E.
E, A, E. Mm, okay. Okay. So, um, out of all the causes here, it's actually biliary atresia. That's the one that cause conjugated hyperbilirubinemia. Yeah, requires surgical intervention. So usually they'll do the CASI procedure is what they call it. So yeah, physiologic jaundice, um you you won't really present with hepatomegaly as well. Yeah. Uh and hemolytic disease of newborn. Um you also most likely present with splenomegaly instead of hepatomegaly. Okay, and that's usually unconjugated bilirubin would be rise. Similar to Crigler-Najjar and Gilbert syndrome, which are both like hepatic causes of jaundice. Is that okay? Okay. No, 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 it's okay. Is everyone still okay to go on? Because we still have quite a few questions, but if everyone wants to stop here, then yeah, let me know. Because again, this session is for you guys, so because we need your responses as well, so that yeah, yes, Felix. Gilbert syndrome presents unconjugated. Oh, you already answered. Oh, extra hepatic. Long-standing colitis. Yeah. So patient long-standing colitis presents with jaundice, stone impacted in cystic duct itself. compressing common hepatic duct. So this was it like resist syndrome. So what type of extra jaundice? Yeah, so you guys are right. Extra hepatic obstructive. So this is a resist syndrome. Yep. Okay, great. Uh Thanks Kevin. Thanks Humaira. Okay, next one. So it's about pancreatic cancer. So pancreatic mass biopsy shows malignant glands in the desmoplastic stroma. So desmoplastic is a reaction that when inflammation happens and over time there's fibrosis and scarring. So you have a lot of granulomatous uh, reactions can be observed. So so that shows malignant glands in desmoplastic stroma. Um, and this patient has jaundice and new onset diabetes. So which molecular abnormality is most commonly associated?
Someone just asked if they could have these questions after to review.
Yeah, definitely. I'll send it to everyone in the email once you guys have fill out the feedback form afterwards. So because we need the email from you guys so that I can send it out to you guys. Okay. Yeah. Thanks, Denise. Uh, does anyone has any answer for this? Or because we talk about risk factors for pancreatic cancer, there are some
We've got
genetic. Oh, sorry.
we've got
Okay.
one D.
D. D is
D.
P16 overexpression. Not really. So the answer is actually B. So KRAS is tumor suppressor gene. So KRAS mutation is actually present in more than 90% of pancreatic ductal adenocarcinomas. Okay. Uh, Next one. Elderly woman presents with small bowel obstruction and pneumobilia. She previously had episodes of jaundice. Which abnormal connection explains these findings?
You have
B.
a B. Two Bs.
Yeah, that's the right one. So B, yeah. So gallstones can actually migrate into duodenum, can cause gallstone ileus, okay, and air enters biliary tree, pneumobilia. Do you guys know what pneumobilia is? I can sh- sh- find a CT image of pneumobilia. Okay, so you look at if you look at CT, um, so usually pneumobilia meaning there's air inside the biliary tree, which is not normal at all. Okay, because the by right shouldn't be having any air in your liver or your biliary tree. So but one common question which consultants also like to ask is after you have done an ERCP, sorry, I think okay, this is not the best one. After you have done an ERCP, you may notice some air, particularly in the duodenum, like close to the pancreas. Does anyone know why? And that's actually a good sign.
Someone said bacteria.
Bacteria, no. It's more to do with the procedure of the ERCP itself. Is it air from?
It's
Is
an
it
air from
air
the incision.
from the incision? Uh, okay. Do you mind? Mm, is it possible to elaborate a bit more? Because in ERCP, uh, where is the incision at? Okay. Um. Okay. So actually ERCP. So ERCP is basically similar to OGDS, also known as esophagogastroduodenoscopy. So it's the camera test. Except for ERCP, so you put the camera, you enter all the way down. Okay, so pass your stomach, and then pass the stomach, and then enter into the duodenum. Okay, so you actually descend into the. So if I share my screen, I think it's easier to explain here. So yeah, your camera will come down here, the descending part of second part of duodenum. So around D2, and is here where they add the major duodenal papilla or the ampulla of Vater. You remember I told you there's a sphincter there. So like a closing, they will only open once there's difference in pressure. So because you want to access the pancreatic ducts and also the biliary tree. So they have to make a cut here. So they actually have to what they do what is known as a sphincterectomy. They have to cut the sphincter. Sphincter sphincter sphinctomy. Okay. So when you cut that sphincter, yeah, air from the abdomen actually goes inside to into that ducts. So that's why you observe pneumobilia after ERCP, and that's actually normal. But if someone has not had any ERCP before, pneumobilia is usually a pathological sign. Okay. Is that okay? Or mm, no reply. But okay. Uh, okay. Probably we just do two more questions. So next is a 55-year-old man presents with painless jaundice and pancreatic enlargement. So the biopsy actually shows lymphoplasmacytic infiltrate and storiform fibrosis. So which condition is this most consistent with? Okay, there is.
So A's.
A
Oh, we've also
pancreatic
got a C and a
adenocarcinoma.
D.
Okay. So okay, we'll go through the options. So in pancreatic adenocarcinoma, so in cancer what's happened, so usually there's tumor suppressor genes gets switched off, or there's a change in promoting uncontrolled mitosis of cells. So we talked about like the most common cell type affected in pancreas, like histopathology wise, more than 90% is ductal adenocarcinomas. So the glands itself in the pancreas actually divide uncontrollably. That's why and then they can invade into other tissues, surrounding tissues as well. Um and in most cases it can metastasize to other places. So that's histopathology wise. So that there actually aren't any lymphocytes or other immune cells involved there. So, but that's how we can rule out pancreatic adenocarcinoma here. Chronic alcoholic pancreatitis also histopathology wise doesn't really correlate with it. Autoimmune pancreatitis maybe, okay, because lymph cells are like your immune cells are involved here. Pancreatic neuroendocrine tumor. So um, so neuroendocrine tumors are tumors that occurs in the neuroendocrine cells. So there are cells that produces endocrine hormones when stimulated by the nervous system. For example, so an example of a neuroendocrine tumor is insulinomas. Okay, there are others like gastrinomas, uh, or glucagonomas. So in insulinomas, so the cells that produce insulin, like the uh beta cells, so they keep on producing insulin. Okay, so yeah, so that's insulinomas. So and neuroendocrine tumors uh usually appear hypervascular under CT scan. So they usually do triple phase CT. So there's the arterial, venous phase, and like neutral arterial and venous phase. So in the arterial phase, they usually capture is like hypervascular. Um, so that's pancreatic, or NETs, or known as neuroendocrine tumor. And then there's primary sclerosing cholangitis, but we talked about that earlier. That's more likely involving intrahepatic ducts. So that actually leaves us with C. Yeah, autoimmune pancreatitis. Okay, so IgG4 related autoimmune pancreatitis mimics carcinoma but responds dramatically to steroids. So there's a method of trying to diagnose or investigate autoimmune pancreatitis. Because if you do your surgical sieve or you remember the causes of pancreatitis, I get smashed. Autoimmune is one of them. Okay. Uh, yeah, one last question. So, um, okay, patient develops jaundice 4 weeks after acute pancreatitis. Imaging shows a cystic lesion near the pancreatic head. So, what's the most likely cause of jaundice here? So, this is a question testing on whether uh the complications of pancreatitis, and also earlier we talked about pancreatic cyst. A, hepatocellular necrosis. If it's necrosis, usually it will be more hardened. There wouldn't be cyst, where usually it's more fluid filled. I think some let's C. Okay, great. And B. Hemolysis. Um, when you have hemolysis, so that basically means your red blood cells break down, so you have high unconjugated bilirubin and a lot of iron flowing around in your blood. So you present with anemia, most likely microcytic anemia, and symptoms can be shortness of breath, dizziness. So you could have
Some
jaundice.
someone
Oh, sorry.
someone just asked if you could explain what biliary atresia is again.
Oh, okay. So biliary atresia is a pediatric condition. So it's usually when atresia meaning uh atresia means not formed. So biliary atresia mean some components of the biliary tree itself is not formed. That's why there is sort of like the obstruction um of bowel flow and biliary clearance. Uh, okay, there is. Yeah. Okay. So that's biliary atresia. And viral hepatitis. Viral hepatitis can also present with jaundice, but they talk here there's they shows a cystic lesion. So there isn't really a correlation between hepatitis and cystic lesion. So the answer here is C, CBD or common bile duct compression by pseudocyst. So pseudocyst is one of the well-known complications after acute pancreatitis because after inflammation, um, so pseudocyst is actually where uh, um, the epithelial cells cover around sort of like a fluid filled cyst. So and the epithelial cells they can be macrophages as well. So this is like after post pancreatitis. So pseudocyst itself, they if they can get really big and then they can lead develop into an abscess as well in worst cases. And if it gets really big, it can also compress on surrounding structures, which include the biliary tree. So when it compress on a structure like the common bile duct, so you have obstructive jaundice signs, pale stools, dark urine, and yeah, you also present with yellowing of skin. So that's why it's C. Okay. Yeah, I think we can end here today. Uh yeah, I think really appreciate everyone taking the time. So I just send the feedback form now first. Moment. Uh
Thank you so much for
yeah,
taking time
just take
out
a second. Yeah.
to teach us about upper GI. So like Joe said, the feedback form should be in the chat soon. And don't forget to fill that out just to receive your certificates and also discount codes for Teach Me Surgery and Pass the MRCS. And our next session, so the next session is on next Tuesday, the 10th of February. That'll be a lecture on lower GI surgery. And make sure to follow us on social media platforms and the links also for those sessions you can find via those platforms. And all of the SPAs will be, sorry, we'll also be hosting SPAs for practice on our social media. So keep an eye out for those. And also don't forget to visit our website. And there's quite a lot of resources there, like question bank with materials, which aren't just for this session, but also from other teaching series. And there's also some summaries and extra questions which aren't available via the social media. And hopefully you enjoyed today and found it valuable and engaging. And thank you again for joining. And hopefully we'll see you next week.
Yeah, oh sorry, just before we end, let's say because next week we might be changing to a new platform. So instead of using Teams, we will try something new, which is a new platform called Career Book. So we will advertise more about it on our social media and also do keep tabs on it because I think that platform itself is much more easier to operate and after the session itself, once you scan the QR code, uh and you generate out the feedback form for you and then you auto generate a certificate for you as well. So that's why we are likely transitioning to that platform next week. But we will uh um announce it on our social media as well as through our group chats. So do keep notice of it. Yeah, and hope to see you guys in our future sessions. Yeah, thanks a lot for taking the time to join today. Appreciate it, everyone. Yeah, I'll send out the slides and the recording to you guys.
Thank you, everyone.
Yeah, thanks, Steven.
Hi, sorry, can I just ask a
Hi.
quick question? Thank you so
Yeah.
much for the talk.
No
I
worries.
think there was like some more questions, like number 11 and things that we
Yeah.
hadn't done. Is there a way
Yeah.
to get the questions to...
Yeah. So once you fill out the feedback form and I get your emails, I'll send out the slides, the recording, as well as the questions document to you guys.
Ah, okay. Okay, sorry, I think you mentioned. Thank you. So which is I think you might have is
Uh,
it the link that you provided?
yeah,
Perfect.
in this chat here, this uh
Thank you so much.
yeah, no worries. I can send it.
Thanks. Have a good evening. Bye.
Yeah, you too. Okay.
Bye.
Bye.